Hello, I'm Jen Sherr, a pediatric endocrinologist and professor of pediatrics at Yale School of Medicine.
And I'm Kurt Midyett, also a pediatric endocrinologist, medical director at Midwest Pediatric Specialists in Overland Park, Kansas.
Welcome to this live social media event titled Basecamp for Ketone Monitoring Part 2, Uncovering Areas of Need. Kurt and I are very excited to have you join us on social media, and we encourage you to send us your comments and questions on whatever platform you're on. Kurt and I will respond to them either during our conversation or at the end during Q&A. So you may be wondering why this discussion is titled Part 2. Kurt, would you tell us a little bit about this educational activity and curriculum?
Absolutely. Back in May of this year, a survey was developed by Dr. Kristen Castorino and was published on Medscape Education. It was a 26 question survey, and it was asking clinicians about their knowledge of ketones and ketone monitoring. We looked at how the respondents answered and to those questions and uncovered, I think, some areas that we felt were needing to highlight a little bit further. And I think that's what we're going to discuss today.
That sounds great. So let's get started and uncover our first area of need from the survey. Now, when we're discussing the survey results, we'll refer to how primary care providers, diabetologists and endocrinologists, and pediatricians answered these questions. It's important to note that for pedi endos, they may have self-identified either as pediatric providers or as endocrinologists. So we're not really sure which category they may have fallen into. So the first question from the survey that we would like to review states, according to a 2021 consensus on continuous ketone monitoring, the risk of diabetic ketoacidosis, or DKA, begins to increase at which plasma ketone level? So, Kurt, when we look at the data, nearly 57% of the primary care providers and 62% of pediatricians didn't know that the risk of DKA begins to increase, beginning at a plasma ketone level of 0.6 millimoles per liter, while 55% of the endocrinologists didn't know this. What are your thoughts about this?
Well, I think it highlights the fact that the majority of doctors don't know much about plasma ketone monitoring. And I think we as endocrinologists are in that same category as well. I think it just emphasizes the fact that ketones have not been the major talking points that they probably should be when we're thinking about DKA. And while plasma ketone monitoring is available and has been available for many years, it's still not widely used by many of our practitioners and many of our patients. And I think that that's why we see such a large number of providers who don't have that understanding.
Yeah, I absolutely agree. And then we're thinking about how we look at measurement of plasma ketones. Can you talk a little bit about how we might define the various levels and what might indicate risk associated with the measures that we take?
Absolutely. I think we have some very clear data on what is considered to be normal and abnormal. And as you can see, probably on the slides that are in front of us, monitoring plasma ketone levels, we think of normal or nothing that we need to be worried about would be less than 0.6 millimoles per liter. We start to see a slight increased risk when the levels get above 0.6 and between up to 1.5 millimoles. When we're getting above 1.5 millimoles, that's when we're starting to really have the conversation about ketosis and diabetic ketoacidosis. And that's when we really start to have the conversations about an action plan, what needs to be considered, what should be done and anticipated. But then when we get above 3 millimoles per liter, that's when we clearly are in a high risk area for DKA.
That's great and so helpful to understand where those thresholds may lie. So when we're talking about ketones and DKA, which ketone body is the predominant one that we see?
Well, let's all go back to our biochemistry days in medical school, which either sends a shudder through all of us or not. But beta hydroxybutyrate is the key component, and that's the one that we need to focus on. The physiology of DKA is something that I feel is so important to clarify is that we need to really think of this as an insulin deficiency issue. It's not a glucose problem. So many times we say, oh, the blood sugars are very high, they must be in DKA, or their blood sugars are not high, therefore they're not having a problem. That's not the issue. The issue has to do with the physiology of insulin. And when insulin is low, the body misinterprets that and starts to try to focus on producing as much glucose as it possibly can. When it maximizes its ability to get glucose from the liver or from glycogen, it starts to look for other sources, and that's where the ketones come in. The body starts breaking down fats. Fats get broken down, ketone bodies develop, and that is the key. It's not a glucose problem, it's an insulin problem.
I think that's such an important concept to be thinking about, and really appreciate how well you just described everything. Because I do think in medical school and in training, this really wasn't gone over in much detail. And so now, as we learn more, understanding the physiology helps us understand how to put this into clinical practice. So, in our survey, we noticed that 44% of primary care providers and pediatricians did not know that beta hydroxybutyrate was the predominant ketone during DKA, and they chose either acetoacetate or acetone. What are your thoughts about this?
Well, again, I think it highlights the fact that we have educated our patients, or really maybe our providers, and on this idea of acetone. And we talk about the fruity breath, the things that we learn in trying to analyze and evaluate a patient who has DKA or ketosis. Well, the key really is to focus on the beta hydroxybutyrate levels. There is a dynamic change between the acetoacetate and the beta hydroxybutyrate, and when we see DKA rising or developing, it's the BHB or beta hydroxybutyrate levels that are going to be the key. While acetoacetate and acetone are important and we need to understand them, our focus in terms of education for providers and patients really needs to be on the BHB.
That's excellent. So now that we've defined DKA, what do we know about its prevalence? In our survey, about half of primary care providers, diabetes and endos, and peds providers recognize that a third of adult cases of DKA occur in people with type 2 diabetes. Do you think that DKA may be overlooked in people with type 2?
Absolutely. Again, it goes back to the metric of insulin deficiency, not glucose issues. And patients with type 2 diabetes themselves can have insulin deficiency. And we can see it in a couple of different ways. It can be somebody who is having a long-standing history of type 2 diabetes over many years that has led to a point where they do have an absolute insulin deficiency and they can have risk for DKA. But we can also see kind of a relative insulin deficiency in which patients who may be very sick, they may be in the hospital, they may have extra stressors, so they're seeing these counter-regulatory hormones, cortisol and catecholamines, that are leading to changes in glucose release and insulin release, which also then creates this spiral. And eventually they can lead to even further imbalances between glucagon and insulin, which is driving this lipolysis. And once you see the fat breakdown, you're going to see the keto body development. And that, I think, is the key. So it's not, again, type 1, type 2, it's insulin. And insulin deficient, those patients are going to be at risk.
Yeah, and I think that's an excellent point. As pediatric endocrinologists, we see people diagnosed so young, and we know data from the Today study that has now shown increased complications. These individuals are insulin deficient in their 20s, in their 30s. They're showing complications. So we
Yes.
have to be aware that they're at risk too for development of DKA. So as we think about that, and are there certain populations where diabetes-related ketoacidosis is at greater risk of developing? In our survey, we noticed that when asked to choose those at low risk for DKA, respondents actually incorrectly selected populations where a patient was at high risk for DKA. So specifically, some of the answers that were endorsed were a Latino male with type 1 who was on MDI therapy, a 40-year-old male with new onset type 1 with obesity and high A1C levels, and women with type 1 who are pregnant. Can you tell us a little bit more about these high-risk populations, Kurt?
Absolutely. And I think that those three, patient descriptions, I think highlight this, is that these are the patients that are at risk. Okay, we can see kids, okay, that we know are going to be at risk. I think those that are underinsured or uninsured that may not have the same access are going to be at greater risk. We can see those in ethnic groups and minority groups are at a greater risk for developing DKA. And also, I think it's the patients that are new to the diagnosis of diabetes. These are patients that may not even recognize that diabetes is something that they have, and they keep assuming that the illness or the symptoms that they're having are related to something completely different, which then leads to them being in a very significant compromise potentially at the time that they present to a healthcare provider. In particular, I think you have to think about very young kids, those less than 5. Those, unfortunately, are still the ones that have the greatest morbidities sometimes associated with DKA. But women who are pregnant are also at greater risk for this. And those patients that we mentioned earlier that have, an illness or newly diagnosed type 2 diabetics that may have a relative insulin deficiency due to the complexity of what's going on inside them at that time. Those are all those patients. I think we see a newer group of those using SGLT2 inhibitors. Those patients, it's not so much that the medicine is causing the issue, it's a misunderstanding of the problem. Patients who are using the SGLT2 inhibitors sometimes will see a relatively lower glucose level, but relatively lower glucose levels does not necessarily mean that they couldn't be at risk for DKA. So assumptions are made that maybe they don't have a problem when their blood sugars are lower than they would expect, and they can be at a greater risk, which highlights the need to understand how to monitor these and giving education appropriately about ketone monitoring.
No, that's excellent. So let's move on to monitoring. In the survey, respondents were asked when people with diabetes should monitor their ketone levels. And based on the 2024 ADA standards of care, the recommended glucose threshold to check ketones is 240 milligrams per deciliter. In our survey, only 58% of primary care providers and 52% of PEDS respondents knew this. What is your thought about this?
I'm going to sound like a broken record here, Jen, but it's an insulin issue, and we have so long told people to monitor glucose levels, and there's a clear understanding, either finger stick blood sugars or now continuous glucose monitoring. This is something that is part of the lexicon of what we do in the management of diabetes. But unfortunately, ketone monitoring becomes a secondary issue, and unless you're somebody who does it every day like we do, it's not on the top of the list of something that needs to be thought of. And so monitoring ketones is critical to this. And when blood sugars rise, it doesn't have to be a blood sugar that's 600 or 500, like the time they come into the emergency room. These are levels that are dynamic. And as those blood sugars start to move above 200, and especially above 240 milligrams per deciliter, that's when ketone monitoring should be had. And it needs to be done regularly and frequently in order to understand whether or not it's rising or falling. And that's the difference between urine ketone, and we're going to get to this a little bit, versus the blood ketone or plasma ketone monitoring. If someone's sick, okay, and we also have to highlight, I think, you and I know how many times that we've had that, kid come in and mom said, oh, he had a stomach bug and they were throwing up and they were ill. But guess what? It was the fact that they were ketotic that was leading to those symptoms, and recognizing those symptoms, I think, is key and emphasizes where ketones need to be monitored.
Yeah, I think that's really interesting. We're both pediatric endocrinologists, looking at the ISPAD, or International Society for Pediatric and Adolescent Diabetes, their sick day guidelines. And it really highlights, be sure to talk about risk of ketones at diagnosis. Do it at least annually. Do it opportunistically. And make sure that we're going over the risk and supplying people with the tools needed to make sure they can go ahead and assess for ketones. A lot of times in my clinic, I find individuals will say, well, I've never had them in the past. I'm like, that doesn't mean you're not going to get them. And so this past year at ADA, we know that there was a session that was presented that focused on hyperglycemic crisis in adults with diabetes. And this session reviewed a recently released consensus report co-authored by a number of internists and endocrinologists representing a multitude of professional organizations. And in this new report that's published in Diabetologia, it highlights that DKA can occur even when glucose is just over 200. So instead of using that 240 threshold, it's now saying, well, we can diagnose DKA at this lower glucose threshold. And in fact, in the paper, they highlight that about 10% of cases of DKA occur in those who have glucose levels under 200. So that euglycemic DKA that you were talking about with SGLT2 use in those with pregnancy. And so I think it really speaks to we've got to go ahead and get away from this glucose-centric approach and move more to, times that we need to be monitoring, making sure people have the tools available and thinking about it, keeping it top of mind if you're feeling ill or anything else is going on. So let's move on to recommendations for sick day management. These have not changed, but in our survey, 54% of primary care providers and 44% of pediatricians did not know that ketones should be checked every 4 to 6 hours. Do you feel that there's confusion here?
Again, just as you made mention to, this idea of changing this conversation from a glucose centric focus to an insulin or ketone centric focus. What is the physiology at hand, and why is it so important to monitor this? And so again, we're going to tell patients to check blood sugars, well, of course, but what we're really most interested in when we're discussing the risks for DKA, and why I think some of our primary care colleagues might be a little bit misinformed, is that this idea that ketones can be dynamic. And just as you highlighted this idea that blood sugars may not be the key. And so if a blood sugar of 180, somebody could be ketotic at that point in time. And understanding that, I think, focuses our educational goals on getting the information to the patients. What are the symptoms that can be associated with ketones? And if those symptoms are there, you have to assume that this is going to be the key. And in order to understand that, you have to check ketones in order to be able to get confirmatory information about where they're going to go.
No, I think that's excellent. So at the start of the discussion, we reviewed the physiology of DKA and explained why beta hydroxybutyrate is the predominant ketone during DKA. In our survey, we asked clinicians which method of ketone testing is currently used to detect beta hydroxybutyrate ketone bodies. Why is blood testing using a capillary meter the preferred method to detect beta hydroxybutyrate?
Well, I think it's first and foremost the only way in which we can actually check beta hydroxybutyrate levels. Urine ketones are acetoacetate, and when we are monitoring that, there is a different metric and a different dynamic. And when somebody moves into DKA, the acetoacetate conversion to BHB, beta hydroxybutyrate, is going to be the one of the primary things that we can see. And those levels will rise very quickly at the beginning of someone who has DKA. And the other challenge we have is just the fact that even though we talk about this, and we as a pediatric endocrinologist, preach the importance of ketone monitoring, I will tell you a large number of my patients still don't routinely do this, mainly because it's not accessible. It's not covered by their insurance plans, or it's too expensive, and they just don't routinely use it. So it's a very important topic that even we as endocrinologists, I think, are still at a deficit.
No, absolutely. I know we talk about it all the time in clinic and encourage people to keep ketone monitoring available at home. And sometimes, just talking about how the reasons why beta hydroxybutyrate, which is going to give us that quantitative measure versus that qualitative assessment that we see, and we also recognize there's this delayed clearance of those urine ketones. So as you see here in the red, we can see that acetone takes longer to go ahead and exit the system. So unfortunately, at our hospital system, we measure urine ketones, in individuals who hospitalized. I'm on service this week and we're tracking ketones with each void. It's not really telling me everything I need to know, but it's what we're utilizing inpatient. And I really think that blood measure, again, represented in that blue, is going to be so much more accurate. It's going to give you a better sense of when ketosis is truly resolving and we can move forward with next steps in terms of plan.
Yeah,
So
and
can
I
you tell
also
us a
think
little bit?
I
Yeah,
also would say to that is that it's very important to also recognize that there is an expiration date on urine ketone strips, and the number of my patients that are probably using expired strips probably would be embarrassingly high. So another talking point, even if that's going to be used, it's critical that they have something that is going to at least give them something in reliability.
absolutely. Can you tell us a little bit more about the urine ketone testing methodology?
Yeah, it's measuring acetoacetate, as I said, and it's a nitroprusside reaction, and it's just a color test. And so we'll probably have a slide up that I'm talking over right now and looking at. We think of purple or blue as large, and a lighter pink or red is much is tends to be mild or negative. And so the relationship between that, large ketones in the urine should reflect, again, large ketones in the blood, but also recognize that there is a dynamic change in the beta hydroxybutyrate levels, and they are going to clear more rapidly as compared to the acetoacetate.
Great. And I have to say, in terms of everything, I have patients who send us, pictures via my chart of their urine ketone levels to tell us, okay, what's going on, where are things at? And it's hard. People don't know how to judge exactly where things are. I also wanted to make the point, Dr. Lori LaFell from Jocelyn always highlights, where do we keep our urine ketone strips? In the bathroom. What's going to happen when they're in the bathroom? They're going to become less effective because they're exposed to moisture and everything else. So even if we have them, we're probably not doing the best in terms of measuring. Um, and then, can you tell us a little bit more again about the points we want to highlight in terms of DKA resolution? What do we really want to focus in on here?
Well, again, it goes back to the physiology, the biochemistry. These are chemical equations, and these pathways are important. And so, as ketosis is developing, there is a drive for lipolysis, and lipolysis leads to acetoacetate development. Acetoacetate rises, and as someone moves into DKA, the beta hydroxybutyrate levels rise very rapidly. But as we are treating somebody with DKA, with insulin, again, insulin deficiency, the beta hydroxybutyrate levels can fall more quickly than the acetoacetate levels. And in fact, just since it's a equilibrium, as one part of the equation starts to diminish, the acetoacetate levels will rise, which will then lead to perhaps even a misinterpretation that things are worsening because, oh, they say, oh, you went from a lower ketone to now your ketones are even higher, maybe in the urine. And again, it's not an indication that they are necessarily worsening their DKA. Very common conversation. I know with you being on call this week, I'm sure that's going to be, you'll get a call from a nurse that will tell you those very things. So
100%. And I have to share, so we do have something that we use in our clinical practice to help leverage and train people about what to do in terms of management of ketosis at home. And so with our EMR, we can go ahead and update the total daily dose at every single visit. And this plan is generated that goes over what we mean by measuring ketones, what we want to do, what steps we want to take. And one of the nice things I got called by the ER last night at midnight, and I said, look in the letters tab, you're going to find this, and let's go over exactly what we're going to do. So it helps us streamline our process. So as we near the end of our discussion and think about how much diabetes technology has evolved, one of the greatest advances has been continuous glucose monitoring. Do you foresee in the future that we might be able to have something similar for ketone monitoring?
well, I'm certainly hopeful that, and there has been some recent information that there is going to be development of a continuous ketone monitoring that could partner well with continuous glucose monitoring. In the same way, we have gotten away from this snapshot of measuring glucose levels. In the past, we had their diabetic logbooks and their logbooks, and they would write each of the finger stick blood sugar levels, and we would we would pontificate in clinic on the changes that need to be made. And all I recognized was how little I knew until I actually saw the continuous glucose monitoring. I think that is going to be something that we're going to see developing into the ketone monitoring as well. To have continuous and dynamic understanding of where ketone levels rise and fall, it could be very powerful, especially those patients with the automated insulin delivery devices, the dynamic information that we need. They're using short-acting insulins that can wear off very quickly. If there's an infusion site problem, they can develop DKA at a greater risk. Those are all the things that could be very powerful in having a continuous ketone monitor.
Great. And as we continue our discussion, I just want to highlight for our attendees, if you can go ahead and scan that QR code to claim credit and review our disclosures, that would be excellent. But we're going to continue the conversation because I'm definitely really excited about continuous ketone monitoring. I especially think about youth who come in and we see our frequent flyers, right? And we talk about the importance of measuring for ketones, and we try and make it so that we can avoid repeated admissions. And I see this as something that will allow us to safely manage individuals at home. And I did want to share that, I've had the opportunity to study a CKM that's in development, and it's been really amazing. We've been able to conduct insulin suspension studies in individuals on pump therapy. And what we've seen is that interstitially measured BHB align with plasma and capillary samples of BHB. And we actually found that ketosis was detected even when glucose levels hadn't breached that 240 threshold. So it really, again, highlights everything that we know. We don't want to use this glucocentric approach. And we're really excited because we're on the edge of just getting started with some pivotal trials. And so in our survey, we noticed there was a big gap in understanding of continuous ketone monitoring. The majority thought that the methods we have discussed, including blood and urine measures, could provide continuous ketone monitoring. So, I think it's critical to understand we don't yet have a technology to allow us to understand the whole breadth of what's happening with ketone measurement. I really wonder, and Kurt, I would love your thoughts on this, whether or not we'll find new thresholds that we should be implementing for clinical care. Similar to that 70 to 180 that we use for time and target range, maybe it's not 0.6, maybe it's a lower threshold. Maybe we'll be able to refine our entire approach once we unleash this new technology. So, any thoughts, final thoughts that you might have in terms of everything?
Well, I would agree 100%. I think that we're going to have more questions moving forward. And when we go into this area of continuous ketone monitoring, the idea that it is not dynamic, as endocrinologists, we recognize hormones themselves are quite dynamic, and the ketones that we're going to see, in an athlete, in a 2-year-old with type 1 diabetes versus a 48-year-old with diabetes, and in pump versus multiple daily injections. I think there's going to be a whole host of information that we're going to glean from this, which is really going to help us as providers, but also help our patients and their families better understand how to reduce. And I think it's very important to recognize the number one cause of morbidity and mortality in pediatric patients is DKA. Okay, in those with diabetes. And so to this day, that has not changed over these many years. And it's so critical that we emphasize that education.
Yeah, and I just want to highlight, there's a comment that came in regards to the benefits of using a ketone or carnivore diet to help improve health. And, one of the preliminary studies assessing the use of continuous ketone monitoring looked at individuals who are on these low carb diets to see if they were reaching that level of ketosis. So this technology could be definitely utilized for individuals trying to reach that level of ketosis. And I just think, the future holds a lot of opportunities for the technology. So I'd like to thank you for providing your expert insights and interpretation into the survey data. We definitely uncovered a few areas of need, but hopefully we've answered your questions and provided you with a better understanding of the importance of ketone monitoring in your patients with diabetes. There will also be part 3, where I'll be speaking with Professor Ketone Dituria, and together we'll provide our top 5 takeaways in the survey. You'll be able to find that program shortly on the Medscape Education Clinical Advances page titled the CGM Toolbox, So please be sure to check that out. To our online audience, thank you so much for your participation. Please be sure to go ahead and scan that QR code, get your credit, and review the disclosures that are listed there. And Kurt, it's been a true pleasure talking to you this evening.
Well, it's been great talking with you today, Jen, and you brought up some great points, and look forward to hearing the next part of this study.
Great. Thank you.